Hello, my name is Lakeisha Amos Jones, and I will be sharing with you an experience with a patient who presented to clinic for diabetes follow up. My patient is a 54-year-old white male with a complex medical history who presents for diabetes follow up. He reports difficulty adhering to his prescribed insulin regimen due to concerns about hypoglycemia, especially when he is unable to eat because of frequent food impactions related to an esophageal stricture. He reports that he does not routinely monitor his blood glucose levels and instead relies on how he feels, checking only when he believes his blood glucose is too high or too low. During this visit, his in-clinic blood glucose was 306, and after being notified, he self-administered insulin per his usual regimen, and the nurse was with him and confirmed this administration. Additional details regarding his current condition include: location, this is ongoing concern with management diabetes due to GI complications. Quality, he states he feels off when blood glucose levels are too high or too low. Severity, blood glucose levels frequently elevated. Recent A1C is 8.9%, and again in office blood glucose level was 306. Duration, he has difficulty with diabetes management and it has been ongoing for a couple of years. The timing, non-adherence is more problematic when he experiences esophageal symptoms. And context, he states he avoids insulin if he hasn't eaten due to fear of hypoglycemia. Modifying factors. He reports using insulin based on how he feels. Does not use consistent blood glucose monitoring. Methamphetamine use prevents GI from performing outpatient procedures, leading to ED visits instead. And the ED visits are frequent. In fact, he's going to the ED about every 2 weeks. The patient verbalizes frustration with the GI team, who refuse to perform esophageal dilations while he is under the influence of meth. He questions why the ED can perform the dilations, but GI cannot. He admits to daily meth use by inhalation, and he has never attempted to stop. He declined a substance use treatment referral during this visit. His past medical history includes type 2 diabetes mellitus, chronic schizophrenia, cannabis-induced psychotic disorder with delusions, diabetic neuropathy, peripheral arterial disease, cervical radiculopathy, GERD, esophageal stricture, exocrine pancreatic insufficiency, disorder of endocrine pancreas, anemia, psoriasis, and multiple pulmonary nodules. His surgical history includes pancreatic cyst, which was removed in 2015. He also had C6, C7 spinal fusion, and the date has not been specified. Social history, again, he uses meth daily by inhalation. Tobacco use, previously used daily, but now he reports as only socially. Alcohol use was previously daily, but now reports only socially. His diet is a pureed or soft diet due to the esophageal stricture. He lives in an apartment alone. And his marital status is he's separated with adult children. The only family medical history reported is his father had CABG back in the 1960s. Review of systems are as follows. General, fatigue, frustration with eating limitations, GI, dysphagia, frequent food impactions, and GERD symptoms. Endocrine, poorly controlled diabetes, inconsistent blood glucose monitoring. Neuro, he has peripheral neuropathy symptoms. Psych, chronic schizophrenia, and meth use disorder. For the other systems, he denies any symptoms today. Physical examination, he is alert and cooperative. He's alert and oriented with no focal deficits noted. No murmurs heard. S1, S2 clear. Lungs are clear to auscultation bilaterally. The abdomen is soft and non-tender. His skin, there are some cirrhotic plaques present, and extremities, no edema or signs of peripheral neuropathy. Diagnostics, he had the point of care glucose in clinic, which was 306. His A1C was last labs in general was done on the first week of March. A1C was 8.9%. His blood glucose at that time was 259. His bond is 29 and creatinine 1.92, which indicates worsening renal function, possibly stage 3 CKD. Nephrology input may be considered if trend continues. His current medications are Creon, 36,000 units. He takes 2 capsules PO 3 times a day before meals and 1 capsule with snacks for pancreatic insufficiency. He has glucose 4-gram tablets with a SIG of true 4 tablets PO, PRN for hypoglycemia. He uses insulin Aspart 100 units with a flex pen. The SIG is to inject 6 units sub-Q 3 times a day, 5 to 10 minutes before meals for diabetes. And my patient reports that he never does this. He says that he waits until he eats and see how it's going to go. And if he's able to eat and, things go well, then he administers the insulin right after he eats. If he's unable to eat, then he skips the dose, because in the past, when he's done that, he's had hypoglycemia and he doesn't want to experience that. He also takes Glargine 100 units, Sapin, inject 18 units sub-Q every evening for diabetes. Pantoprazole sodium, he takes 1 tablet by mouth, BID, 30 minutes before meals for GERD. He also has Accu-Check Guide test strips and glucose monitor. Okay, so for assessment, type 2 diabetes poorly controlled, inconsistent blood glucose monitoring, non-adherence to insulin regimen due to food intake concerns. Esophageal stricture, he has recurrent food impactions, recurrent frequent ED dilations, and non-compliant with GI follow-up due to meth use policy. And actually, he's often a no-show for his appointments, both in primary care as well as with GI. Methamphetamine use disorder, he refuses treatment, impacts ability to receive outpatient GI care. Chronic schizophrenia, psychotic disorders, managed, but insight is limited. Stage 3 CKD, creatinine 1.92, bond 29, as I said earlier. Likely multifactorial. Diabetes mellitus, volume status, possible nephrotoxic exposure. Exocrine pancreatic insufficiency, he's on Creon and compliant with supplementation. GERD and pancreatic endocrine disorder is managed with pantoprazole. Substance use and nutrition related functional decline. Now, my pharmacological plan is to continue insulin regimen as prescribed, reinforce proper use of Creon, maintain pantoprazole BID before meals, continue glucose tablets as needed for hypoglycemia treatment, recommend renal function monitoring, adjust meds as renal function declines, continue Accu-Check test strip with goal of blood glucose monitoring at least 2 to 3 times a day. We also discussed the use of a continuous glucose monitor, which the patient was open to. I was excited about that. And my thought is that having a continuous glucose monitor may improve engagement by reducing the burden of finger sticks and offering real-time feedback on blood glucose trends. We will evaluate insurance coverage and coordinate with clinical pharmacy for initiation if feasible. Non-pharmacologic treatment plan, We strongly encourage consistent blood glucose monitoring with logs. Refer for dietitian for diabetic friendly soft puree diet plan. Reiterate importance of insulin with reduced intake and educate on dosing adjustments. Motivational interviewing to explore readiness to reduce methamphetamine use. Education on difference between emergency and outpatient care settings. Educate patient on safety concerns of performing procedures under substance influence, and to encourage continued engagement with clinical pharmacists. He actually he no-showed for his last appointment with the clinical pharmacist. So during this visit, when I saw that he was coming in and saw that he no-showed, I actually contacted the pharmacist and let her know he was coming in, and we agreed that she would be available during that time. So once I finish, she will come over, and she came over and spoke to him. And we just, with a little education, and got him rescheduled and reiterated the importance or what the goal was for him meeting with her. And he agreed to show up. Okay, so referrals. Ophthalmology, he's overdue for a diabetic eye exam. Clinical pharmacy, I just spoke on, that has been rescheduled. Substance use disorder program, a referral has been submitted, although he is not quite ready, but he's thinking about it. So when he was telling me about, he doesn't understand why if the ED can perform the dilations, why can't GI? But then he says, but really, why can't I stop using meth? So I asked him, well, what happens when you stop using meth? He said, I never have stopped. I said, well, is that something you're interested in doing? Would you just like to sit down and talk more about it? And he was agreeable. So I put in the consult and we'll see what happens. Where was I? GI. We are encouraging him to return to outpatient clinic for scheduled esophageal dilations. Consider future referral to nephrology for CKD if renal function continues to decline. He will follow up in 4 to 6 weeks with primary care, follow up with clinical pharmacy as scheduled, and we will monitor renal labs and A1C in 3 months or sooner if clinically indicated. Patient engagement strategy. I think it's important for us to set short-term realistic goals. So let's begin with checking the blood glucose at least once per day. We want to reinforce that insulin can be adjusted, not stopped during low intake. Frame glycemic control as a way to prevent ED visits and improve energy and mood. Maintain non-judgmental approach emphasizing harm reduction, and build rapport and consider peer support or behavioral health involvement. This has been my patient. I'm actually really excited to work with him. I'm really trying to improve on the motivational interviewing and building rapport and trust. And as I told this patient, let's work together. Let's partner together. Communicate with me. Be honest with me so that I can understand where you are. And then we can work together where you are to set small goals to improve overall health. And he was amenable to that. He really wants to work on his, improving his health status, but he's lost a lot of trust in the healthcare system. And I'm working diligently to rebuild that trust. Also, he says that he wants to continue to live, that he has reasons to live for. He has some grandkids he's, looking forward to spending more time with. So I think we're going to just keep focusing on small goals at a time. I'm also going to schedule bi-weekly nurse visits to have him come in and check his blood glucose level. I'm concerned about that because he frequently no-shows. So we do have a plan B that if I can just get him to check the blood glucose level one time at home, and then the nurse will call him and just ask him for those readings instead of him reporting. So we'll see how it goes. Thank you very much for your time, and see you next time.